Hi, and welcome to week 7 of BMI 598 Population Health Management and Analytics. As usual, I'm your instructor, Ken Farrell. So, this will be the final video lecture, and we're going to cover just a few topics. We're going to take a look at some project methodologies, primarily the Plan, Do, Check, Act methodology that is really applicable for any kind of industry improvement. It's used quite a bit in healthcare. We'll also take a look at some of the newer CMS payment mechanisms, specifically around bundled payments. There's quite a few of those that are available now. We'll take a quick look at the midterm assignment, how you did on midterm, some of the places that you missed, some points, so that hopefully will help you on the final project. And of course, we'll take a look at the final project, set some expectations about what needs to be done in order to score well on your final project. So process methodologies is basically, there are different styles of this in all sorts of industries. Healthcare has adopted several different types. We'll look at one in detail. But as you've learned over the past few weeks, the first thing you need to do is identify an opportunity. So that's typically a cohort and some sort of a goal that you want to achieve. You have to identify what data is available to first identify your goals. So identify your baseline, identify what your improvement is going to be for those particular measures, and then identify the data that's going to help you identify, track how you're doing with the project. And finally, identify the improvement project itself and track the progress as that improvement project is being put into place. So one of the more popular ones in healthcare, it's very popular in nursing, is the Plan, Do, Check, Act cycle or process management, developed by W. Edwards Deming, who is the individual who coined the term or the phrase, in God we trust, all others bring data. So you can imagine this is a very data-centric type of methodology. So in the plan stage, basically, you identify how can we improve a process. So whenever you find some sort of opportunity, and this can be applied to pop health, whenever you identify a cohort of patients that have some deficiency or some goal that you want to get to, come up with an idea on how to improve a particular or several health outcomes for that particular cohort. So once you come up with an idea on what you're going to do, then you go ahead and actually execute that. So that's the do step. You implement the plan, and as your plan is starting to take flight, you're going to repeatedly check the data as it comes back to validate whether it is appears to be having a positive effect. And this is important. The data step here is very important, and we've talked about the importance of IT in the whole population health realm. So if you have a cohort of patients, you have 2,000 diabetic patients, and you implement some new program, and actually when you take a look at your final project, you'll actually be reviewing a potential plan. So this is a plan that a third party is going to bring to you. So you'll be looking at this plan, and what you need to do is find the data that you can track to say, is our plan working? You need that data to be fairly uh, readily available. You don't want to have to wait 6 months to figure out whether or not your new plan is working, because at that point it may be too far along. You may have put yourself at a great deal of risk in any one of the triple aims, but you need that data to come back. And in fact, we just rolled out a project where we were literally checking the data 8 days into the project to see how the data was looking. Even though it was a small sample size, it started to give us the comfort level that things were going as planned. And then we did another review after 4 weeks. So it's critical to have that data available fairly quickly. Now, some of your pop health plans may not really lend themselves to short turnarounds. So your plan may be to help lower HbA1c, for instance, in diabetic patients. That HbA1c levels don't change very quickly. So that may be a 6-month, might be the earliest that you can really check and see how your patients are doing based on some new lifestyle change or some intervention or some product that you're having them use to help them manage their diabetes, for instance. So you really do have to take a look at the timescales of your projects, but you do want to be able to have data as quickly as possible to make sure that your plan is actually working. The check stage is really where you do the rigorous data analysis, compare your baseline values to your 6-month values, for instance, and then put some rigorous statistical analysis around whether or not you're seeing the change, whether you're meeting your goal, whether you've met part of your goal, whether you've made no difference. This is the check stage where you do put this rigorous data analysis of the Pop Health program, review it with your stakeholders, and then determine if things are going the way they are. If they are, this is the act step. If they are going the way that you expected, this new process now becomes cemented in your program. So you basically accept the change. If you're not seeing the results that you anticipated, if you're not seeing, for instance, the savings that you were expected, you're not seeing the clinical improvement in the patient, you're not seeing patient experience improve, for instance, for your triple aims, then you would reject the change and basically go back to the drawing board and come up with another idea potentially. And even if you do accept the change, even if you do find a program that is working, you could still continue to iterate through this PDCA cycle. So you can come up with another way to improve even more where you're at. And that's just an iterative approach to improving your processes. So this is one of the more common methodologies in healthcare, PDCA. There are other ones in healthcare, lean methodologies. PDCA is actually part of the Six Sigma. If you've heard of Six Sigma quality program, PDCA is an element of that. But there are others out there, and just pick a methodology and stick to it, because most of them are pretty good and will help you keep your project, your process change on track. Okay, so now we're going to talk about some of the newer payment models that have, particularly CMS has implemented. There are other commercial payers that have implemented similar models for their payments, but CMS is basically the pioneer when it comes to holding healthcare systems accountable for value and cost. So we'll go over the BCPI model and talk about the 4 different models that they have for this bundled payment plan initiative, bundled care payment plan initiative. Talk about the different models and where they are right now. So it's basically 5 models. These are the first 4 we'll talk about. There's a 5th model now called the Advanced, which is currently accepting participants. Model 1 is actually, and I'll advance to the slides. Model 1 is actually not even around anymore, but 2, 3, and 4 are still active. And as you can see, this is a great slide. If you want to refer to the different models, this is a fantastic slide. We'll actually go into each one of these models individually, but this slide is a very good reference for the different models. So Payment 1 model, as I mentioned, is no longer active. It concluded at the end of 2016. It started in about 2012, and it basically was a bundled payment. And what bundled payment means is that when there's when a patient has some sort of episode, instead of billing for every tiny little thing that you did, every test you ran, every diagnostic image that you ordered, every medication that you gave, every consult that was performed, you basically get paid a single payment for the entire episode of care. So there's usually they usually agree to a handful of different types of episodes. For instance, a heart attack or a sepsis event, spinal surgery, those kind of things are considered an episode of care, and they derive these bundled payment amounts based on historical data and trying to get costs under control. The primary issue they had with Model 1, and it was for hospitals, so this was basically for inpatient events. The primary issues was that hospitals had a hard time initially getting physicians enrolled and engaged. And I know many of you in your midterm project actually latched onto this issue of physician enrollment, physician engagement when it came to ACOs. It's also very important for these hospitals that had agreements with physicians and provider groups, but they did have a very hard time enrolling and engaging physicians. And this program actually died kind of a very quick, gruesome death in my estimation. similar to some of the ACO models that we looked at earlier, they lost a lot of participants as each year rolled by, and eventually the last one dropped off in 2016. So Model 1 wasn't the best and didn't do very well. Model 2, so this is a bundled payment also. These are all bundled payments, but this is for the acute hospital stay and post-acute period. So that means anything that happens after they leave the hospital for up to 90 days. And depending on what the episode type was, there was a 30, 60, or 90-day follow-up period. So you had to cover all of that. If they had to return to see a primary provider for a checkup, that had to be taken into account. So you had to make sure that your bundle payment was going to cover that. Currently, there's 421 participants in Model 2, including Banner Health. So Banner Health is one of the more popular or more successful ACOs. They're also involved in this Model 2 payment. Individual providers, as they provide services for these patients, are still paid under the old fee-for-service model directly from CMS. But then CMS actually takes a look at everything that they paid for an episode of care, and then they either on a episode by episode basis. So they look at each episode, and if the amount that was charged for that particular episode was less than what the bundled payment amount is, CMS will send a check to the participating healthcare organization for the difference. If the total amounts that were included for all that episode of care were greater than the bundled payment amount, then it would be a penalty and the organization would have to pay that money back to CMS. Model 3 is a very different population. So this is primarily for skilled nursing facility and rehab long-term, what they call LTAC, long-term acute care, and home health agency. So these are bundled payments for 30, 60, or 90 days worth of care. Individual providers, again, are still paid under the fee-for-service model, and then the retrospective awards, meaning once the episodes, the 30, 60, or 90-day episodes of post-acute care. So this doesn't include the inpatient part of the visit at all. This is solely after they leave the hospital. If they go to one of these types of facilities, they're bundled payments for taking care of these patients for 1, 2, or 3 months. And then again, just as it is in Model 2, the bills are basically collected because, as you can see, individual providers are still paid under fee-for-service and they bill directly to Medicare. Then CMS identifies whether or not for each of these episodes the overall spending was less or greater than the bundled payment amount, and then it either cuts a check or the organization has to reimburse CMS the difference. Model 4 is similar to Model 1. Currently, there's only 2 participants on here. Individual providers do not bill CMS in this model. It covers acute, includes 48 acute episodes of care again, and these 48 include things like spinal fusion, bowel obstruction, sepsis, cardiac arrhythmias, a whole bunch of types of episodes that typically can be constrained very nicely with costs. So organizations can opt into these 48 acute episodes of care, and they have to cover all of the they get one bundle payment from CMS, and from that they need to pay their people and then any of the providers that are also providing care for these patients. One caveat to this is that this model also, that episode includes any post-acute care or readmissions for 30 days after the discharge. So if they send the patient home early from the hospital thinking that, okay, we don't want the person to stay in the hospital too long because we're working under bundled payment, and if that patient isn't really ready to go home and they have to come back to the hospital, anything that happens after that, an ED visit, if they have to go see the doctor at an outpatient facility, all those things are covered for 30 days after discharge. Again, there's currently only 2 participants in this model. So those are the 4 bundled payment models. I really do encourage you all to go to CMS, take a look at their Innovation Center. There are over 100, I believe, different programs around payments, around providing quality care. Some of them are very specific to a specific cohort, such as oncology or diabetes. Some of them are very broad, just payment, like these bundle payment initiatives, and you really should go through all those because although it's not exactly population health, uh, these programs are all pop health, have the flavor of population health, and could be something that either an organization you work for is being paid under. So it's good to know exactly how those payment models work. Or you could fashion your own sort of care pattern after some of the programs that CMS has designed. So I really recommend that you go out there and just take a look. They're broken down by types of program. There's quality programs, there's payment programs, there's ACO programs. I do recommend that you become familiar with that CMS Innovation Center. It changes quite frequently, so you need to kind of keep an eye on it and see what programs are coming up. Very good source of information for basically kind of keeping abreast of where healthcare is going in terms of payments and quality and virtually everything in the AAA. So finally, the bundle payment plan that's currently accepting applications called BPCI Advanced. They are taking applications right now from hospital group practices. The program period begins next year. There is upside and downside risk on the advanced model. There are 32 types of episodes. We talked about episodes before, things like cardiac arrhythmia and sepsis and spinal fusion. 29 of these episodes are inpatient. There are 3 outpatient episodes. And they do use quality measures to affect the reimbursements. 6 of those are from NQF and 1 is from PSI. All right, so we'll talk a little bit about, and this is more just kind of my ideas on the future of population health. Of course, I think you're going to see more and more payment models from government and commercial payers. A lot of these programs are really designed to reduce variation in care. So you're going to see care pathways develop. Care pathways is like a best practice way to manage a particular type of patient. These care pathways are developed by different healthcare organizations, most of them nonprofit. Some of them are developed by academia, but they identify, so for instance, for a patient with neutropenic fever, here's how those patients should be managed. And it will walk through the medications they're supposed to get, the tests they're supposed to get, and what should happen if certain events occur for those patients. Variation from those pathways typically will cause variation in outcomes. So whether it's length of stay or cost or patient satisfaction or complications, those clinical pathways that these payment models are really forcing organizations to adopt drives out the variation in care. There's going to still continue to be a lot of mergers in healthcare organizations. With the shrinking margins in healthcare, with CMS forcing organizations to become more lean and driven towards quality, these are efforts that are very difficult to take on for small organizations. They just don't have the resources to implement those types of changes. So you're seeing a lot of healthcare organizations merging in order to do 2 things. One is to generate economies of scale, so they can have a quality department that can oversee 1,000 clinics or 200 hospitals and be able to do that efficiently because they can invest the money and the resources and repeat a process over and over and over at all these organizations within these larger healthcare organizations. And I would say the second region, primarily for the mergers, would be being able to quickly change processes to meet changing government regulations. So it's difficult to stay on top of all the things that are affected, that can affect a healthcare organization. So if Aetna changes their policies, if CMS changes their policies, you need like an army of people to manage those. And you have to manage those whether you have 1 patient or 1 million patients. So again, there's economies of scale. And another reason I think mergers are going to be more popular is these healthcare systems really want to expand into all the potential domains that they need to be in order to provide an entire portfolio of care for a patient. So they need oncology clinics, they need infusion centers, they need primary care practices, they need acute hospitals, they need radiology centers, they need all of these different components in order for them to, as we talked about with the triple aim, to and with the ACOs, be able to provide coordinated care across a large network. So I think you're seeing a lot of mergers where um, uh, these organizations are picking up like little pieces of occupational health and like I said, these provider groups. So they're trying to become larger and being able to keep all the care under one umbrella, so to speak. I think you'll see integration of things like genomic, proteomic, microbiomic data. So I know at our organization we're beginning to get into genomic data. Proteomic data is how your genes are expressing proteins. So there's a difference between what your genes, what you have in your genes, and what's actually being actively expressed from your DNA. Not a topic to get into too much detail in this class, but those are things I think that you're going to see those best practices start to pick up. We'll start to integrate some inclusion of genomic, proteomic, and microbiomic data. So like what's in your gut, so to speak, for microbiomic data. More and more, you're going to start to see use of patient-centric data, so data that's being generated or is existing around the patient 24/7, not just when they're in the hospital, not just when they're visiting a doctor. So that includes things like social media, your Apple Watch, your wearable devices. Your final project's going to look at, I believe, Wi-Fi enabled asthma inhalers or asthma inhalers that actually record what's going on at the time that you use the devices. So that sort of data will start to play into your overall care. And that's already happening. And a lot of people are actually using these wearable devices, and you've seen the commercials about the stationary bikes that are integrated to a live coach somewhere. So you're going to see a lot of data being generated by these different applications, different devices. Social media is going to be able to be incorporated into part of the patient's medical record to help monitor their care. So being able to see what's happening with sugar levels, glucose levels for a diabetic 24/7 is very valuable to a clinician, as opposed to just getting independent lab results at particular time points. I also do see patients possibly becoming custodians of their data. So um, being able to take your data from provider to provider to get over some of the hurdles of that disconnected care. Uh, there are a couple of genetic companies, 23andMe and Ancestry.com, for instance, that you can actually have your DNA tested, and they will actually send you information about your DNA, like specific information about your DNA that actually can help with your care, like how they design your care. So personalized medicine is something that's coming to the fore in healthcare, which means you have two individual people. You're not just going to do the exact same thing to both patients based on a handful of lab results. You're actually going to look at a variety of different data inputs and then customize the treatment plan based on some algorithms. So this is very popular in oncology. Clinicians in the class probably know that oncology is a highly customized field. They look at all sorts of information before determining on how to proceed to treat various cancers. And that's a good segue into pharmacogenomics, which is kind of a blend of the integration of genomic data. So pharmacogenomics is the confluence of pharmacology and genetics. So changing the way that medications are being administered or the types of medications that are being prescribed based on a person's genetic information. So there are a variety of genetic markers, genetic mutations that are very common that will interfere with the potentially interfere with the medication performing at optimum levels. Some examples of that are there's a mutation in a CYP2D6 enzyme gene, and if you have this mutation, which 7 to 10% of European descendants have, a drug like codeine won't work very well because that enzyme is critical in the delivery of the drug. So codeine actually goes into the liver and this enzyme cleaves codeine into morphine and some other component. And the morphine is actually what gives you the pain relief. And that's slowly done over time as the enzyme is cleaving apart this codeine and releasing morphine into your bloodstream. And without an active CYP2D6 enzyme, codeine doesn't have the same effect as it would on a normal patient. It's just one example of dozens of known genetic and pharmacology interactions that can actually help treat a patient. So instead of going 3 to 6 months down a treatment protocol and then realizing it's not working and try something else, they might be able to head off that sort of ineffective care by realizing that particular medication has little chance to work before they even start down that path. So there's a website called CPIC. I can't recall what it stands for, but CPIC has a whole lot of these recommendations about interactions between known common genetic mutations, what's called primarily called a SNP, which is a single nucleotide polymorphism, which means that one of your base pairs in your gene, in a particular gene, is not correct and creates a non-functional copy of the protein. Those interactions are actually at that website, CPIC, so I encourage you to go take a look at that. I think that's something that you're going to see potentially making its way into the electronic health record and into care pathways in the next 5 to 10 years for particular medications and medications and genetic interactions, gene interactions. Finally, the healthcare information exchange. So this has been the Achilles heel of healthcare for decades, especially during the electronic health record era, is the inability for data to move between systems. And there's a whole lot of reasons. We've talked about those in prior lectures. Why this happens. There's security, there's competition, just technology issues. There's probably a dozen issues why this happens. Legislation is another one. But this is starting to become a problem that has to be solved. This cannot continue this way and expect to see reductions in cost and increased efficiency of care. It just isn't going to happen. So I think you're going to see more moves towards a freer exchange of information. There is some technologies, one's called FHIR, F-H-I-R. You can Google that, take a look at F-H-I-R. It is based on HL7, which we talked about, I think, in week 2 or week 3. But FHIR is basically a set of software, like think of them as little software components that sit on top of your EHR that can respond to requests coming from anywhere and retrieve the data in the same format, no matter if it's coming from Cerner or an Epic or an eClinicalWorks. It has a contract between the calling person and the FHIR resource that will always, so if you want to know about a person's medication history, you make a call to a FHIR, you make a FHIR call, and it will return back a formatted result that is in a way that is always the same no matter where it's coming from. So that's a standardized protocol, if you will. And I think that will become more popular. It's just, they're almost being, the EHR companies are almost being forced into doing this, but it's a necessity. So it's going to coalesce, or it's going to converge to this solution of being able to move data around. And it has to, because as you all are very well aware, one of the biggest problems with our healthcare structure is the amount of waste. And one of the big sources of waste is repeat tests, unnecessary tests. So this is actually a necessary step to eliminate that waste. So some quick feedback on the midterm. Overall, the midterm was very good. Scores were very high on the midterm. There were a few common issues I just wanted to go over. I think this is helpful, maybe for future work and for the final project as well. APA citations. So I saw probably about 20% of the papers had footnote citations instead of APA style. So you can always, there's tons of APA resources, so make sure that you do your in-text citations correctly and you have your reference page formatted correctly. There are websites that you can just Google how to APA cite a newspaper or a website. It will show you exactly how to do that and how to do the in-text citation as well. So it's really unlimited resources for getting that APA information, and there really is no reason why we shouldn't have 100% score on the APA part of the rubric. Um, the lack of an intro and a conclusion paragraph, either one or the other or both. Any good paper of this type should always have an introduction paragraph that lays out the problem or the discussion points. Um, it's almost like a preview of what you're going to talk about in the following paragraphs. And then at the end, your conclusion paragraph should almost recap what your intro paragraph said, just not verbatim. Um, and I always do recommend that if you're making, if it's an argument paper where you're actually posing an opinion, that you devote one of those paragraphs to an alternative viewpoint. And then if you want, you can actually um, address that alternative viewpoint. So play devil's advocate for a paragraph. And the midterm project really didn't have a whole lot of that, although you could have found some ways to make some of those arguments. But overall, the structure I like to see is intro, a couple of body paragraphs, 3-4 body paragraphs, each one substantiating a sentence or parts of a sentence in the intro, then a conclusion that basically recaps what you covered in the paper itself. There was a lot of like very extensive quoting, and I know the quoting will kind of get you out of the plagiarism issue, but I personally, and I think most professors, would rather see you paraphrase what an author is saying and then cite them, which is perfectly legitimate to do. But paraphrase it, you can even reference their name. You know, Dr. Smith stated that, and then you paraphrase what they stated, and then just in-text citation, his name and the year, or her name and the year, and then down in the references, you put the APA citation. So don't have 3-4 sentences all in quotes. I'd rather see paraphrasing and just attributing it to the author. Whenever you use an acronym, CIN, PH for Pop Health, ACO, the first time you use it, you should always spell it out, and then in parentheses after that, put the acronym. And then from there, you can use the acronym as much as you want. There were a handful of papers that mentioned ACO but didn't say what ACO was, said CIN, didn't mention what CIN was, and you can't really assume that the reader of the paper knows what those are. So it's common practice to spell them out the first time and then in parentheses put that abbreviation, and you're free to use that abbreviation as many times as you like. There was a handful of papers that spoke in the first person. I believe that we need to, and that should be minimized for these types of papers. You should be, you can always convert, I think, that into third person form fairly easily, something you should get good at. But these types of papers shouldn't be really spoken in the first person. Other than that, the papers are pretty good. I enjoyed reading them all. I saw you capturing a lot of the same themes. So I saw a lot of talking about the coordination of care, the engagement of physicians, the reduction in costs, the elimination of repeat tests, and I was glad to see that the class had picked up on the main themes of population health and the analytics of population health. So I was very happy to see that. So on to the final project. So the final project is due May 4th. I apologize. The PDF I have is from last year. I cannot find the original Word document. So if there are dates on there, ignore the dates and use the dates I have. And unfortunately, the dates are very similar. Since we don't have a final exam, I'm giving you the final week of the 8-week course to work on the final project. I think the official last day of class is 28th or something, but you have until May 4th. That will mean I have to grade them very quickly over the weekend to get your grades out, and I will grade them as soon as possible. If for some reason you need your grade done sooner for graduation purposes, let me know and I'll put it at the top of the list, but I think that I will get through them pretty quickly. I probably won't go through them as rigorously as I did the midterm, simply because I will not have the resource of time to do that because of the quick turnaround for the grades being due. But I'll do the best I can, and don't let that lead you into a less than high quality paper, because I will pick up on components if you try to breeze by them. 750 to 1,000 words. APA style again, citations again, in text and reference citations. Footnotes should not be in there. Bring some insight to this paper, and we're going to walk through a couple examples of that here in a second. And challenge the findings. So feel free in this paper, and this paper should be written as though you are writing this paper for your boss. So this paper is basically about a third-party company that's bringing this tool to help you with a population health effort. They've brought a bunch of stats and graphs to try to sell you this product. Your job is to be, and your boss doesn't have the statistical and the analytical rigor to go through the proposal or go through the reference material or marketing material from the third-party company, 598 Analytics. And it's your job to go through that and ask questions. If you want to ask for follow-up data, you can. But this is basically, I would write this as a paper, as a review, analytical review. Feel free to use charts. Feel free to use again, you can challenge the findings, you can identify follow-up questions, hey, I believe we should ask 598 Analytics about this, or how long did it take for that to happen? Those sort of things should be in the paper. So you could choose any format that you like, not PowerPoint, so it has to be Word. If you want to do it like an academic paper and have an abstract, an overview, a methods, a results, and a conclusion, you can. If you want to set it up like that, you can. If you just want to do it as a 5-paragraph paper, you can do that as well. So, but what I'm really looking for is your insights. What did you learn from this class about analyzing a pop health program that you could put to good use in analyzing this potential project? So here is the guts of the final project. So again, you're working for a CIN that serves 40,000 adult patients. You have about 3,200 that have asthma, and that's about the national prevalence of 8%. A key for cutting costs for CIN is to help minimize the amount of resources being used by these patients. So that's your goal. This software is supposed to help you do this. And again, asthma is the leading cause of preventable emergency room visits. So the vendor has engaged your leadership and said, hey, we've got this great product. It's a Bluetooth asthma smart inhaler device. And there are some of those actually on the market, so you can go take a look at those. And it's got a bunch of dashboards also that come with it that will help you monitor the patients when they're using their inhaler and help them via an app to give them feedback about their asthma. This third-party company actually handles the shipping of the inhaler and has developed the analytics dashboard for you, and any of the app support that you need will be covered by 598 Analytics. There's no information here about what 598 Analytics is going to charge you, but they've made a lot of claims, and they've had 3 pilot facilities from another company with 750 patients, and they're going to provide. In this paper, I outlined some of those findings. So one of the big findings is the frequency of the inhaler use. So this is a chart that on the top is a chart that they provided that says how often the users are using their inhaler. You would expect if not using it, if they're using it once every 2 weeks, they're probably not going to provide much benefit. They're probably not going to drive the benefits from the program that you'd expect. So here in blue, you can see at 14%, at the beginning of the program, 14% of patients used the smart inhaler, and by the end of this year that they were tracking these patients, they got that up to 24%. And again, green is every other day, red is weekly, yellow is biweekly. So a full half of the patients are hardly even using the inhaler, the smart inhaler, for whatever reason. Down below, what they're showing you, and this is very in tune with what we've learned about pop health. So here are a couple of metrics: hospitalizations per year and ED visits per year. There's a national average, which they curated through combing through some meta-analysis of this type of asthma patients. The baseline information is what what the pilot organizations that they're reporting here, what those organizations saw in their baseline period, meaning before they rolled out the smart inhaler. And then when it says participants, that's what happened with these people using these inhalers for the year. Their hospitalizations per year for asthma dropped from 1.8 to 0, and their ED visits per year dropped from an average of 4.3 per patient, and it was 750 patients, down to 1.1 ED visits per year. So these are very lofty expectations. I will kind of clue you in to look at some of these claims, both the chart and the results, in the context of the 7 failures of analysis that we had in the book by Al Lewis. So that was the Why Nobody Believes in Numbers book that I mentioned. I believe it was in week 5. So I would actually kind of review some of those just to see how these claims hold up. If you have any questions about the final project, you can always email me. We will not have a video for week 8. We will not have readings for week 8. Week 8 is basically your final, but your final is your final project. Your final project's worth about a third of your grade. So this being the last slide and the last lecture for this class, I'll say it's been a pleasure. I've really enjoyed the discussion forums. I've really enjoyed the email that I've received from some of you, meeting some of you in person out at the Mayo Institute. It's been great reading your midterm projects. I really look forward to the final project. Make sure you fill out the course surveys at the end of the year. Tell us what you liked, what you didn't like, so we can improve the course, improve delivery of the course. You can always email me at any time with any questions throughout your academic or professional career. If you think there's something I may be able to help with, feel free to email me at my ASU address. And I generally want to wish you all the best of luck in everything you do going forward and on the final project and on your remaining coursework here at ASU. So with that, I will say goodbye and good luck.